Hello everyone. In this section, I would talk about basics of mechanical ventilation. So the first thing which we need to answer that what is mechanical ventilation? Now, mechanical ventilation literally means breath by machine. So when we breathe ourselves, that's called spontaneous ventilation. And when the breath is realized or given by machine, that's called mechanical ventilation. So if you ask me to define it, what is mechanical ventilation? My answer would be it is a respiratory therapy which is given to a person to maintain near normal oxygenation and ventilation. Now, this oxygenation and ventilation of a person can get deranged due to multiple causes. And meanwhile, that cause is being treated, the support of ventilation and oxygenation is given through mechanical ventilation, right? So, mechanical ventilation is respiratory therapy. It is respiratory therapy which maintains near normal oxygenation and ventilation of patient. Oxygenation and ventilation Now this derangement of oxygenation and ventilation, as I said, this can happen due to primary respiratory diseases or due to so many non-respiratory diseases. So mechanical ventilation is not exactly a treatment. It is a supportive therapy which is given till the time primary etiology is being treated, right? So it is supportive therapy. It is supportive therapy till the primary etiology is eliminated. Till the primary etiology is eliminated. Okay, so this is your supportive therapy, not the treatment which we are doing to the patient. Okay, so this is what is mechanical ventilation, a supportive therapy in which we support or control the respiration to maintain the near normal oxygenation and ventilation till the time the primary etiology which has caused the derangement is being treated by the clinician. So this is what is mechanical ventilation. Okay, now let us just one line about the history. Today the word mechanical ventilation is synonymous to positive pressure ventilation. Positive pressure ventilation. That is what we are practicing today. I'll talk about that there are two ways of giving mechanical ventilation, positive or negative pressure ventilation. But mostly today we practice positive pressure ventilation, and mechanical ventilation kind of synonymously used with the word positive pressure ventilation. Now let us talk about the history of this positive pressure ventilation. The first mention of word positive pressure ventilation was done in the history by Verzelius in 1555. So Verzelius was the first person. Verzelius was the person who mentioned positive pressure ventilation. Was first person to give concept of positive pressure ventilation. Positive pressure ventilation, right? And it took nearly 400 years. It took nearly 400 years to develop the concept which Verzelius gave. In 1955, during the polio epidemic, the positive pressure ventilation, the Emerson company came up with the ventilators providing positive pressure ventilation. So in 1955, during polio epidemic, Emerson company came up with mechanical positive pressure ventilator. Came up with positive pressure ventilators. Okay, so this concept took nearly 400 to develop, right? In 1955, it was first conceptualized by Verzelius in 1555. Okay, now let us talk about the fundamental. How does the ventilation happens? Now, the fundamental of any ventilation is the flow of gas, right? Because of the difference in the pressure. So during inspiration, when we breathe in, the intrathoracic pressure becomes negative. So from atmosphere, the air is sucked in. And when the intrathoracic pressure or intraalveolar pressure becomes positive, expiration happens. So fundamental of the ventilation is same. That is to create a difference in the pressure to move the volume of gas in and out. So the fundamental is to create a pressure difference across the airway to move volume of gas in and out. So to move volume of gas in and out, we have to create a pressure difference, and this can be created by two different means, that is positive pressure ventilation, right, through positive pressure difference, and by creating a positive pressure, by giving a positive pressure, and negative pressure ventilation, right? So negative pressure ventilation. So we'll talk about both of it. Okay. So as I talk about the fundamental, so we have to create a pressure difference. So this is the alveolar pressure, the pressure at the level of alveoli, and this would be the opening lung pressure. Now this is connected through, this is communicating with each other through this airway. Okay. So when will inspiration happen? When the inspiration will happen when the alveolar pressure is lower than the opening pressure of the airway. So the PAO is the airway pressure, and PALV is your alveolar pressure. Okay. So because of the difference in this pressure, then only the gas will move in and move out. So during inspiration, the PAO is more than the alveolar pressure. So the gas moves from outside to the patient's lung, inspiration happen. And during expiration, the opposite happens. During expiration, the alveolar pressure has to be more than the airway opening pressure, then only the gas will move out. So this can be created by two ways. Either during inspiration, we decrease the alveolar pressure below the atmospheric pressure. Then from the atmosphere, air will be sucked in, or we create a positive airway pressure near the opening of the airway, and this positive airway pressure would be more than the alveolar pressure. The inspiration would happen. So this can happen in two ways, and that is what is positive pressure and negative pressure. So let us talk about intermittent positive pressure ventilation. So let us first talk about intermittent positive pressure ventilation. How does the gas moves in? Positive pressure ventilation, popularly called IPPV. Okay. As it is intermittent, so intermittent positive pressure is applied at the airway end. Okay. So ventilator does this work of applying intermittent positive pressure. So ventilator end, the positive pressure is applied intermittently. So if you see this graph, how the inspiration and expiration happens in positive pressure ventilation, intermittent positive pressure ventilation. So this is the pressure, which is the solid line is the airway pressure, and at a particular time a positive airway pressure is applied by the ventilator. This is decreased. So what happens? The airway pressure becomes 0. Then again a positive pressure is applied, then again the pressure is removed. So intermittent positive pressure is applied. So what is the benefit of applying the intermittent positive pressure? So when the positive airway pressure is applied, the PAO is more than the alveolar pressure. The broken line is the alveolar pressure. So it is more than the alveolar pressure. So the inspiration happens, the gas moves. Inspiration happens. So when the gas starts filling the alveoli, the alveolar pressure starts increasing. So the alveolar pressure starts increasing. Okay. And when the positive pressure is removed by the ventilator, the alveolar pressure is more. So what happens? The alveolar pressure is now more than the airway opening pressure. So gas moves out. Expiration happens. When the gas moves out, the alveolar pressure again reaches the baseline. It reaches the baseline. The alveolar pressure reaches the baseline. Now, when the alveolar pressure again reaches the baseline, at a particular time, again the ventilator applies a positive pressure. So again there is a pressure difference. Again an inspiration will happen. Again an expiration will happen. So this intermittent positive pressure ventilation is causing inspiration and expiration. Now, how does this inspiration will happen? How does inspiration cycles into expiration? All this depends upon the mode of ventilation, the mode of ventilator which is selected by the operator, which I will talk about. Now, before we will in very detail talk about the intermittent positive pressure ventilation, the different modes of it. But before that, a brief mentioning of intermittent negative pressure ventilation, which is nowadays of historical importance, not commonly practiced. So let us talk about intermittent negative pressure ventilation. Intermittent negative pressure ventilation. Negative pressure ventilation. Okay. So intermittent negative pressure ventilation. In this, your ventilator, the negative pressure ventilator, mimics the normal ventilation or normal respiration. How? There are different ways of giving intermittent negative pressure ventilation. If you see these two images, the first one, the patient airway is always, or second one also, both in A and B, the patient's airway is always open to the atmosphere. So what is done? We do something at the level of chest. So first one is iron lung and the second one is chest cuirass, right? Cuirass. In both, what we do? We apply a negative pressure at the level of chest. So what happens when the negative pressure is applied at the level of chest? The intraalveolar pressure decreases. Let's say this is your atmospheric pressure. Okay, this is atmospheric pressure, and patient's airway is always open to atmosphere, so it will have a fixed atmospheric pressure. It will be at the atmospheric pressure. So how will inspiration happen? For inspiration to happen, for air to move from atmosphere into the alveoli, the alveolar pressure has to decrease for inspiration, and that is what is done by this iron lung and chest cuirass. They apply a negative pressure and decreases the pressure at the alveoli. So alveolar pressure becomes less than airway opening pressure because of the negative pressure applied at the level of chest. So what happens? The inspiration. For inspiration, the airway opening pressure should be more than your alveolar pressure. So for this, inspiration will happen. So when inspiration happens, the alveolar pressure starts increasing and now it crosses the pressure or the airway opening pressure. So now the expiration will happen. So for expiration, the opposite will happen. The airway opening pressure, would be less than the alveolar pressure. So the expiration would happen. So this intermittent negative inspiratory pressure is applied by devices like iron lung and chest cuirass. Now they are very bulky, as you can see in the image. They are very bulky devices to be used. Nowadays not commonly used, right? So it is not what we are using. This intermittent negative pressure ventilation is mimicking the patient's spontaneous ventilation. Okay, so we'll talk more about intermittent positive pressure ventilation. Intermittent positive pressure ventilation is what is a common practice. Okay, so let us talk about the ventilation. Okay, so as I said, two ways, the mode of ventilation, two ways, that is intermittent negative, intermittent positive, and we will talk about intermittent positive pressure ventilation. Positive pressure ventilation. So this is what we are practicing and this is what we need to discuss. And in this, we will discuss different modes of ventilation. So what do I mean by mode? Mode is the operational function which is set by the operator, by us, to realize the breath by the ventilator. Now, how does ventilator gives breath to the patient? depend upon the mode which has been set by us. So we need to talk about different modes of ventilation. So there are so many modes of ventilation. So if I start writing, now I can fill pages about the modes of ventilation. How there's so many ventilator, different companies manufactures ventilator, and every time a company manufacture a new ventilator, they come up with some new name for a mode, for a particular mode. So there is lot of mode which we need, which is there, and it makes it very confusing to understand. So make things simple, we need to understand the basic modes. If we understand the basic, it would be very easy to understand the nomenclature changed mode, I would say. Rather, I wouldn't say the changed mode, some few nomenclature changed mode, right? Now, we would discuss the basic modes in detail. That would be our target in this lecture. Okay. Now, to understand the modes, we need to understand what is not a mode. Okay. So, what is not a mode? First, we need to understand that. Okay. So, first thing, the term invasive, non-invasive. Now, this is non-invasive is not a mode of ventilation. What do I mean? Now, for positive pressure ventilation, if we are using the endotracheal tube, right? If I am using as a patient interface, so if for patient interface, we are using a endotracheal tube, right? Using endotracheal tube. Then this is your invasive ventilation. Then it is called invasive ventilation, right? It is called invasive ventilation. And if I am using a mask for ventilation as a patient interface, a mask, right? So if I am using a mask, then it is called non-invasive ventilation, right? So we will talk about invasive ventilation first, and then we will talk in the end of this lecture about non-invasive ventilation also. Okay. Then let us talk about this IPPV, INPV. We have already talked about it in detail, that IPPV and INPV, that is intermittent positive, intermittent negative, they are the fundamental principle on which the ventilator operate. So they are not mode. So they are also not mode. So these are the fundamental principle of ventilation. Principle of ventilation. So they are, sorry, this one, they are not mode. Okay. Then supine and prone. Supine ventilation, prone ventilation, or supine word is not used, prone ventilation. Now, prone ventilation again is not a mode. It is a position in which the ventilation is being done. If patient is being ventilated in prone position, we call it prone ventilation. And any mode can be used in prone ventilation. Got my point? So, this word, prone ventilation, this means the ventilation in prone position. Ventilation in prone position. Okay. So, we'll talk about this also in the end of this topic, that what is the benefit of prone position ventilation, in which any mode can be used. Okay. So, these are not modes. Now, let us talk about the mode of ventilation. Mode of ventilation. So, before we talk about mode of ventilation, right? What does the mode do? Mode gives a mechanical breath. So on this mode depends how the mechanical breath is given. So on it depends how a mechanical breath is delivered. Right? So we need to understand how a mechanical breath is realized. What are the factors which define a mechanical breath? Then only we can understand that which mode is delivering the mechanical breath in what way, right? So one mechanical breath can be defined by 4 parameters. How it is triggered, that is how does it start, how it is cycled from inspiration to expiration, how it is limited or controlled, that is volume control or pressure control, what is controlling that breath, and what is the baseline above which inspiration expiration is happening. That is called the baseline pressure. Baseline pressure. Okay, baseline pressure. So one breath has 4 parameters to define it, right? So the first parameter which I told you is how it is triggered. So how it is triggered means how inspiration starts. So how inspiration starts. So how inspiration starts. Now, inspiration can start either by patient initiating it. So we call it patient triggered breath, or a machine can trigger it. We call it time triggered or machine triggered breath. So patient triggered or machine triggered. Machine triggered. So patient triggered or machine triggered, right? Anything can happen. Okay. Then we'll talk about the patient triggered, machine triggered. Then how is the breath cycled? How from inspiration the breath is cycled into expiration. So how from inspiration breath is cycled to expiration, Okay. So how can breath be cycled from inspiration to expiration? Well, it can be time cycled according to the inspiration expiration time which we have fixed. So it can be time cycled. That is the commonest way which is practiced. And or it can be flow cycled. Flow cycled. That is, when the inspiratory flow decreases, the breath cycles from inspiration to expiration, and this flow cycle is only operable in your pressure support ventilation. Okay, rest all are time cycle. Okay, then controlled. How is a breath controlled? So what is controlling the breath? Volume, a fixed volume is controlling, or a fixed pressure is controlling. So it could be two. How how breath is controlled, or limited, right? So how the breath is controlled or limited? So two things can happen: volume control, pressure control. Volume control, pressure control. So we'll talk about it. Okay. Now, baseline pressure. How we are breathing? We are breathing spontaneously over our FRC, functional residual capacity, and this can be increased by applying something called PEEP through the ventilator, positive end expiratory pressure. So this baseline pressure above which the inspiration and expiration happens, and that is realized by fixing by something called PEEP, positive end expiratory pressure, right? Positive end expiratory pressure, or something called PEEP, is what we have to understand. So these are the 4 parameters which defines a breath, and different modes control these different way of triggering, cycling, controlling, and baseline, and this is how different modes comes into existence, and we'll talk about it. Okay, so before talking about mode, little more about something, how the breath is controlled or limited, volume or pressure control, we need to understand. Okay, so volume control mode or volume limited mode. In volume control mode or volume limited mode, what we fix is tidal volume, and that much tidal volume limits the breath. Okay, so in this, in this, a fixed tidal volume, a fixed tidal volume is chosen by the operator, by the operator, right? And this is what is delivered to the patient. Okay, now when a fixed tidal volume is being given, see, rather than calling it volume control, it should be called flow control, right? So what happens, till a fixed tidal volume is given, a fixed inspiratory flow happening in the patient, till the volume which is fixed by us is realized, is given to the patient. So it is flow controlled rather than volume control. It is flow control. What happens, a fixed flow flow of inspiratory gas is given through ventilator till the tidal volume is not achieved, till the fixed tidal volume is not achieved. So till the fixed tidal volume is not achieved, a fixed flow is given. So even during end inspiration, the inspiratory flow is happening in volume control ventilation. So as you can see that as the tidal volume would increase in it, right, the flow is fixed in this. So because of this, what happens that the initial when the patient starts the breath, the requirement of flow is more, right? But when the patient is towards the end of his inspiration, the requirement of flow is less. But this is not happening in volume control or flow control mode, rather I should say it. There is a fixed flow. So this makes it little uncomfortable for the patient compared to the pressure control. The other problem with this mode is uneven alveolar filling, because during initial also there is a high the flow, and as the tidal volume increases there is still the same flow, so uneven your alveolar filling. So the major problem of this mode is, the major demerit of volume control mode is that patient ventilator asynchrony can happen, right? Inflexible flow because of inflexible flow. Now latest ventilators with volume control mode, they don't have this square pattern of flow. I mean, they don't only have this square pattern of flow, they have ascending pattern or descending pattern of the flow also. So this problem of inflexible flow causing the asynchrony to some extent has been reduced. Then the other problem is uneven alveolar filling. So this is one problem of volume control. And the main problem is, if the patient has a poor lung compliance and we are giving a fixed tidal volume, then the pressure variation in the alveolar is very much high. So a fixed alveolar pressure is not there. So alveolar pressure in this mode, alveolar pressure in volume control mode, pressure depends on the lung compliance and the set tidal volume So, right, we have ventilator has to deliver a fixed tidal volume, but patient has a poor lung compliance. To receive that tidal volume, the pressure is rising very high, right? So it depends upon the lung compliance, tidal volume, and also on other factors, but mostly on the lung compliance. Okay, so this is volume control mode. If we see different scalar of volume control mode, scalar means the graph between flow time, pressure time, and volume time. So scalar of volume control ventilation, right? We have flow time, pressure time, and volume time, three graphs which we need to see. In flow time, the most common flow pattern which is used for volume control, I have depicted here. This is the square flow pattern. In this, a fixed flow throughout the inspiration is delivered, right? And when the inspiration, the tidal volume is given, the required tidal volume, the flow becomes instantly zero. Okay. Now there are other flow pattern also nowadays in volume control, which has decreased this patient ventilator asynchrony caused by inflexible flow. The square pattern of the flow is not a very good pattern. Deceleratory pattern, which is there in the always in the pressure control, is considered a better flow pattern. Okay, but this is the commonest one, so I have written it here, a fixed flow, and then expiration happens. Okay, now pressure. Now pressure in volume control ventilation may vary from breath to breath. It depends upon the compliance of the lung. It may exceed what we require, what we want, right? It depends upon the compliance of the lung, also on the resistance of the lung. Now, if you see this graph, the volume control ventilation has a peak inspiratory pressure and then it decreases to the plateau pressure. Why? This because at the end of inspiration also there is a flow happening. So airway flow would not become zero at the end of inspiration, right? So there is a peak inspiratory pressure and then a plateau pressure. Okay, so this peak inspiratory pressure and plateau pressure, we can distinguish, we can see through the pressure time scalar of volume control ventilation, and this will give us so many idea. If patient has a high peak inspiratory pressure but a normal plateau pressure, the airway resistance is more. If patient has a overall normal pressure but high plateau pressure, then the compliance of the lung is poor. So this graph help us in diagnosing the diseased conditions, like disease which increases the airway resistance. They will increase the peak inspiratory pressure, and disease which decreases the compliance, right, they will increase the plateau pressure. So plateau pressure depends upon the compliance, the peak pressure depends upon the resistance. That is, peak pressure is the plateau pressure plus the pressure in the airway, the conducting path. So that the airway pressure is peak pressure minus plateau pressure. So we will able to distinguish that where is the problem. That is a beauty of your pressure time graph of volume control ventilation. Okay, then volume time graph of volume control ventilation. A fixed tidal volume will be delivered. So this is your volume control ventilation. Okay, now let us talk about the pressure control, pressure limited ventilation. In this, a peak airway pressure is fixed, so, or plateau pressure, because it has a one fixed pressure. So in this, a high flow is delivered by ventilator to achieve fixed airway pressure, fixed alveolar pressure, which is fixed by us, fixed alveolar pressure. Now this fixed pressure which the operator fix, to achieve that pressure, a high flow is delivered by the ventilator. So during the start of the inspiration, a high flow delivered by the ventilator, and then the gradually flow decreases, right? So within this is a flow time graph of pressure control ventilation. So within this, the tidal volume has to be delivered. So a fixed pressure, and within this the tidal volume has to be delivered. The high flow is delivered. Got my point? So in this, what will happen? The airway pressure, or let's say the alveolar pressure would remain constant. Pressure would remain constant, right? In this, the flow pattern, the decelerating flow pattern, when the patient requires more flow during peak of the inspiration, they are getting more flow. So patient and ventilator synchrony is better. So better patient and ventilator synchrony, right? Then even filling of the alveoli, more even filling of alveoli, right, happens in pressure control ventilation or pressure limited ventilation. Okay, if we see the scalar of the pressure control ventilation, that is your pressure time, your flow time, and your volume time, right? What we see, a fixed pressure in the pressure time graph. Flow time, decelerating pattern of the flow in flow time, and in volume time, the uneven volume can be given. So this is the demerit of pressure control ventilation. Fixed tidal volume may not be delivered. Here, the tidal volume depends on the fixed pressure, If you increase the pressure, more tidal volume, of course. Fixed pressure, compliance of lung, resistance of the airway, and resistance of airway and other factors also. Mostly on the pressure which we have set, compliance and the resistance of the airway. Okay, so let us see the difference between the pressure control and the volume control. So pressure control or pressure limited, volume. So limited control, same thing again and again. So you will find it pressure limited or pressure controlled, same thing. Okay, so tidal volume in pressure controlled. So not fixed. This is not fixed. As I told, it depends upon the pressure, depends upon the compliance, depends upon the resistance. Volume limited. This is fixed. Fixed tidal volume will be delivered. Okay, peak airway pressure. Peak airway pressure. Now, peak airway pressure in pressure limited, fixed. Right? In volume limited, not fixed. Again, it depends upon the compliance, upon the resistance of the upper airway. Then patient comfort, pressure limited, more, volume limited, less compared to pressure control ventilation. Got it? Now, remember that studies have compared both the mode and they found no difference in mortality and morbidity of the patient. So, volume and pressure control, both modes are equivalent in comparison of morbidity and mortality of patient on mechanical ventilation. So there is no difference. Whichever mode you are more comfortable with in a patient or which mode patient is tolerating in a better way, that should be chosen for the patient. So whether volume control or pressure control depends upon the operator who is setting the mode and also what is the patient tolerance. Some patient may tolerate the volume control better, some patient may tolerate the pressure control better. There is something called which is a better mode. Both modes are equivalent in morbidity and mortality and both can be used. They have some differences which we need to have in our mind, and these differences depends upon the lung condition of the patient, the compliance, the resistance, etc. Okay. Now let us talk about the modes, how all these features are provided by different modes. So and before mode, one more thing which you realize, the breath is baseline pressure, which I talked about. So I forgot about the baseline pressure. Baseline pressure in case of person on ventilator is your positive and expiratory pressure. Positive and expiratory pressure, right? Or PEEP, popularly called PEEP. See, we breathe. Our PEEP is our FRC, functional residual capacity. That is the volume above which inspiration expiration happen. This is increased by applying an expiratory valve in the expiratory limb of the ventilator circuit. So in ventilator circuit, there is one expiratory valve which is attached. And when the pressure in the during expiration falls to the set pressure of the PEEP, right? The expiration is cycled from expiration to inspiration, right? So inspiration and expiration happens above PEEP, right? This is achieved by applying a valve in the expiratory limb. When the patient, what happens? The expiratory valve closes when the baseline pressure is achieved. So when during expiration, the patient alveoli goes into the baseline pressure or the airway baseline pressure is achieved, the expiration is cycled into inspiration. Got it? So this is PEEP. Now PEEP has positive factors, negative factors, right? So what happens when we are applying the PEEP? The baseline alveolar pressure is raised. So alveoli, the surface area of the alveoli remains expanded. So what happens? The O2-CO2 exchange happens from a wider surface area. So positive end expiratory pressure increases the oxygen and carbon dioxide exchange. right? So this improves, basically it improves oxygenation in a patient. So this improves oxygenation in a patient, improves oxygenation. Other thing, it prevents the collapse of the alveoli. The next important thing which it does, this prevents collapse of alveoli, the cyclical collapse of alveoli. So by maintaining this baseline pressure, the alveolar collapse is prevented, right? So atelectroma is prevented. So decreases the atelectroma, which is nowadays considered the most common cause of alveolar injury. So this is prevented. Okay, so this is the benefit. The demerit of PEEP is that when the PEEP is applied, especially high PEEP, baseline PEEP, minimal PEEP, not a problem. But when a high PEEP is applied, the intrathoracic pressure is increased. And whenever intrathoracic pressure is increased, the venous return decreases. Venous return decreases, hemodynamic imbalance can happen, right? Apart from this, a very high PEEP can itself cause barotrauma. So disadvantage of PEEP is, number one, increased intrathoracic pressure. This increased intrathoracic pressure can cause barotrauma. The other problem of PEEP is your decreased venous return. The other problem is decreased blood pressure because of decreased venous return, and all the other problem because of decreased blood pressure, that is your decreased urine output and other issues, right? Decreased your venous return, this can increase intracranial pressure, etc., because of inappropriate venous clearance of the central nerve of the CNS. Then decreased blood pressure can decrease urine output. So all these are disadvantage of PEEP. So we need to titre that at what minimum PEEP the good oxygenation, prevention of the collapse of alveoli is happening, right? We need to set the patient baseline pressure on that pressure. Okay, right. Now how do we set the PEEP? Now PEEP is set, right? Whenever the ventilation starts, whenever we put a patient on ventilator, a minimal baseline PEEP is always mandatory. Minimal baseline PEEP should be set, right? So this is set, normally it is 5 centimeter of water. So this is the baseline PEEP which we need to put. Okay, the PEEP is increased by titrating it with the required FiO2 for required oxygenation, by titrating it with fractional inspiratory oxygen concentration for required oxygenation. So we have a table which we have discussed in the ARDS topic also, in which PEEP and FiO2 ratio, how we gradually increase PEEP and FiO2 to achieve the just adequate oxygenation in a patient between 60 to 70 mm of Hg. So to achieve this, we need to titrate PEEP and FiO2, right? So this is how the PEEP is set. Okay, now parameters on which the breath is delivered, just a quick revision. So breath is delivered, number one, triggering. Number two, that was cycling. Number three, limiting or control or limit. And number four, the baseline pressure. This is the fourth thing on which the breath would be delivered, and modes which we would fix would decide how these four things will happen. Okay, so this is what is mode. Mode is the operational parameters which will help us, according to which the ventilator will decide how the breath is triggered, cycled, controlled, and what is the baseline pressure. Okay.